to the lipid clinics. You see the slides of, you've seen the slides of the lipid clinics rolling. And my name is Alberico Catapano, and one of the coordinators of the activities of the lipid guideline, the lipid clinic activities. Just a few words before getting started. Today we have the first of a series of webinars, and this webinar will be related to the presentation of Professor Rob Hegele. Many of you may know Bob. Bob is in Canada. He's one of the leading authorities in genetics of these lipidemias, and that's why we asked him to give a seminar on this area. This would be an introductory seminar made by a very authoritative person. The seminar will last about 40 minutes. After that, we will have time for 20 minutes for free discussion. Please feel free to answer any question. Here you see in the slide and the presentation the following future webinars and the topics. The dates have been settled early for the next one that will be on July 22nd, and then we'll resume towards the end of August. In the meantime, between the two seminars, you will receive also a commentary on a contemporary paper on these lipidemias with slides you can download and use, if you wish, for your local or international presentations. Having said that, I will give the word to Peter CEO, who will engage you on how to pose questions in the live part of this webinar, which has been pre-recorded for the Rob Hegele. Please, Peter.
Hello, everyone. Peter here from the EAS office. You can post your questions in the chat box, and we will take them after the lecture. So without further ado, I will start the lecture from Rob Hegele.
Hello, it's Robert Hegele from London, Canada, and I'm going to speak to you today on the topic of genetic disorders of lipid metabolism with a special focus on familial hypercholesterolemia. This slide shows my disclosures. Although there are many types of hereditary dyslipidemias, today we will focus on hypercholesterolemia, hypertriglyceridemia, perhaps a little bit of time for others, but mainly focusing on the first two. This slide shows the increase in knowledge of our understanding of familial hypercholesterolemia through the ages. When I began in medical practice in the late 1980s, we used to think that FH was a disorder of 1 in 500 in the population, predominantly autosomal dominant due to mutations in the LDL receptor gene. Certain clinical features that you see there. The diagnosis in those days was clinical, and the treatment was bile acid resins, niacin, statins had just made an appearance, and apheresis for homozygous familial hypercholesterolemia. This is even still today what many people think when they think of heterozygous familial hypercholesterolemia. However, the right-hand side of the slide shows our current knowledge. We now understand the condition is much more common than we thought, probably 1 in 250 to 300. The genetics is certainly more complicated than just a single gene. There are at least 4 major genes, some minor genes that can also give a phenotype that looks like familial hypercholesterolemia, and then on top of that there is polygenic risk. Clinical features are the same. In fact, clinical features in some way are diminishing because we're making the diagnosis at an earlier age and people are being treated at a younger age. We are also now including DNA diagnosis in making the initial diagnosis. And there are many, many more treatments, fortunately, available that you will hear about in other talks. In addition to the statins, there's ezetimibe and drugs that are targeting PCSK9, agents for homozygous FH, lamidipide, anti-ANGPTL3 medications, and several new medications. So we are living in a golden age. We have a wealth of new treatments for familial hypercholesterolemia. I can show a similar slide for the development of new treatments for severe hypertriglyceridemia, or at least our understanding of severe hypertriglyceridemia. The prevalence we used to think was a super rare disorder that was recessive, the so-called lipoprotein lipase deficiency, or familial chylomicronemia syndrome. Physicians used to think this was very, very rare, but in fact severe hypertriglyceridemia is actually more common today. We recognize it through population studies, although the pure genetic form is still quite rare. Now, in 1987, there were two genes, lipoprotein lipase and, of course, apolipoprotein C2, ApoC2, and there were clinical features of severe hypertriglyceridemia, anorexia, nausea, vomiting, acute pancreatitis, hepatosplenomegaly, lipemia retinalis, eruptive xanthomas. Diagnosis was largely clinical, and control was really through dietary mitigation. The other medications for severe hypertriglyceridemia were not as effective. Today, we've expanded our view, and we are including multifactorial chylomicronemia. So this is not then just familial chylomicronemia syndrome, which is extremely rare, 1 in 100,000 to 1 in a million, but in fact if you include patients with triglycerides over 10 that have it on a more broad genetic basis, usually polygenic risk, this is much more common in society, about 1 in 500. It still seems rare to internal medicine specialists, but it's actually in lipid clinics we see it more commonly. But it is mainly the polygenic type, not the monogenic form. Even in lipid clinics, it's still largely polygenic compared to FH, which is still predominantly a single gene disorder. The clinical features are the same, and we realize now also that there is a risk of atherosclerotic cardiovascular disease with very high triglycerides. Diagnosis sometimes includes a DNA testing with a targeted lipid panel, and we have many, many more treatments, as you can see in the slide, fortunately for our patients. Some of you may remember the Fredrickson classification, type 1, type 2A, 2B, type 3, and so on. We really think that this is an outmoded ontology, not really that useful. It's still for older doctors like myself. It's perhaps a shorthand that makes some sense, but in terms of understanding the organization and classification of genetic dyslipidemias today, we don't think that this Fredrickson classification really holds much value in light of our understanding now of the genes that are involved in monogenic dyslipidemia. So here is a revised way to look at the ontology or classification of dyslipidemia. So first of all, it's the major lipid or lipoprotein fraction that's perturbed, be it LDL, be it triglycerides, be it HDL. And then the deviation can be mild to moderate, and the levels are shown there for your reference. Usually for mild to moderate elevation, there is possibly a genetic susceptibility, possibly some mild to moderate polygenic susceptibility, and then usually secondary factors on top. For a severe deviation, defined there as you see, so LDL greater than 5 millimoles per liter, triglycerides greater than 10, or HDL depressed, so HDL less than, say, 0.7 millimoles per liter, for argument's sake. These are more likely to be single gene disorders with that degree of elevation, also a polygenic predisposition plus secondary factors on top. Now, a word about DNA variation. I'm going to be talking in this presentation about two types of DNA variation. Common variants that have small effects that are important for polygenic susceptibility, and rare variants that have large pathogenic effects that may be the entire explanation for the phenotype in the patient, monogenic or Mendelian traits. So rare variants versus common variants. So the DNA variation, be it rare, be it common, when you are sequencing or looking at the patient's genome, the DNA, the variation qualitatively looks the same. This slide shows a stretch of DNA. It's monomorphic, the same sequence on both copies, but then at a particular position, you will notice that there is a variant. It could be from the father inherited an A, an adenosine, and then from the mother inherited a C, a cytosine at that position. Now, what determines then, it looks the same in the patient, but then you have to do a population study to determine, is this rare or is it common in the population? And as I mentioned before, there is starting to be a distinction biologically and clinically between a rare variant and a common variant. The rare variant having the potential to be much larger of an effect and more likely to be pathogenic and clinically fully explain the disorder in the patient. So this slide shows the example of a rare variation. So this is, again, it looks a certain way in the result from the patient. The way that you know that it is rare is that then you are analyzing a whole population and you see, oh well, it's only that one person out of 300 that has that variant. So it's a rare variant. Now, the rare variants still can be neutral. There's nothing to say that they have to be pathogenic. But more often, say in something like the LDL receptor in the coding region, if it's a rare variant, very often it is pathogenic. So this would be the single gene disorder, like familial hypercholesterolemia, having a prevalence of 1 in 300 in the population due to a rare variant. So as it turns out, we know that there are 25 different monogenic dyslipidemias, named syndromes. The most famous, familial hypercholesterolemia, heterozygous and homozygous. But there are others. Familial defective ApoB, A-beta lipoproteinemia, heterozygous and homozygous hypobeta lipoproteinemia, Tangier disease, LCAT deficiency, all of those. If you make the whole list, it adds up to a list of 25, and there are 25 causative genes, and these are all conditions where the phenotype is fully explained by one of those rare variants occurring in one of these genes. So this is the list, and as you see, it's both increased LDL, the hypercholesterolemia, but also there are decreased LDL states, A-beta lipoproteinemia. So again, the same principle though, a single variant explains it. Now these can be dominant inheritance, some of them or most of them in fact are recessive inheritance. The same for triglycerides. You can see the high triglyceride familial chylomicronemia syndrome, or then decreased triglycerides, and then for the HDL disorders that you were familiar with. And this table shows in more detail what I showed you in the previous slide, and the reference is there if you are really interested to see this list of disorders listed by the primary lipid deviation, and then the inheritance, the gene, the chromosome, and various literature references. And for completeness sake, this shows where all of those genes on the previous slides, where they all map within the human genome. So they map throughout, different chromosomes. So each one of these, a rare variant of a large effect, is sufficient to explain the phenotype in the patient with the syndrome. And I don't have time to discuss today, but these syndromes, because of the severe lipid elevation, they often have associated clinical features summarized on this slide. And if you are interested, you can go and look at the primary article which describes the individual disorders and the perturbation and exactly the clinical features shown here. So with this background, I will present a couple of cases. This is a case of familial hypercholesterolemia. A patient of mine, a 34-year-old truck driver, referred for secondary prevention of coronary heart disease. His father and 2 paternal uncles had fatal myocardial infarctions under the age of 50. In this patient, His total cholesterol untreated at age 29 was 10.6, LDL 8.52, so very high. He was not treated by his family doctor. At age 33, he suffered an anterior wall acute myocardial infarction. He was shown on angiography to have diffuse coronary disease. 3 stents were placed in his coronary circulation, and he was started on wide, broad-spectrum anti-atherosclerosis treatment, including atorvastatin. My colleagues and I published this patient for Canadian doctors to raise awareness of familial hypercholesterolemia. So these are the physical findings from this patient: thickened Achilles tendons in panel A, xantholasmas in panel C. He had tendon xanthomas in the tendons of his fingers in panel B, and then a corneal arcus, hopefully, I hope you can see it, in panel D. So all patients I see in clinic, and I'm very fortunate, everybody gets targeted DNA sequencing. It's almost part of the physical examination now, our targeted DNA analysis, which simultaneously looks for a monogenic variant. And so in this case, this patient had a splicing variant in the LDL receptor gene, an intron 14, a single base pair change. Very rare in the population, but this was enough to explain his disease. He had no secondary causes of hyperlipidemia. But then on top of that, we simultaneously do assessment for polygenic risk that I will explain to you in a moment. And in addition to this monogenic variant, he had a very high burden of polygenic small effect common alleles that put him at the 99th percentile of such a large number of these SNPs, or common polymorphism, that would raise his risk of high cholesterol. So he had 2 reasons for high cholesterol: a monogenic susceptibility and a polygenic susceptibility occurring together. So we said that he has heterozygous familial hypercholesterolemia, a single allele, then on top of that, strong polygenic risk. And this slide shows his DNA sequencing, and it shows here in the lower panel, it's the position of his single base pair mutation, which is right at the intron-exon boundary, which is then causing the abnormal splicing. And really, there's no receptor, no protein that is made from this copy of the allele, or this allele of the gene. So just to show you, if you focus on this column here, the second column from the right, shows his LDL level throughout the years. So he started with an LDL of 8.52, then when the statin was added, it came down, but still was very high. Ezetimibe was added, it came down to 3.82, and then we had him actually on niacin for a long time, and his LDL was 3.3 and 3.1, and then finally, when evolocumab, so he was one of the first Canadian patients, or North American patients, in fact, I believe the first in North America to start on the phase 3 study, the Rutherford trial, and he received evolocumab, and his LDL since that time, so really since about 2011, has been excellent. And he's been asymptomatic, and so this has made a dramatic change in his medical condition. Again, briefly, just to remind you, heterozygous or monoallelic FH, prevalence in the population, in most populations, of about 1 in 250. It has those clinical findings that are classical: early atherosclerosis. The 3 commonest forms, the LDL receptor, about 85 to 90% of rare variants occur in the LDL receptor, but 5 to 10% in ApoB, and then there are about 1% of variants occur in PCSK9. There are over 3,000 variants of the LDL receptor that have been reported in patients with this condition, deposited in disease databases. And the inheritance pattern is shown here. So this is autosomal dominant inheritance, so that really one copy of that mutant allele is enough to cause the full expression. It's really fully expressed. So if you have an unaffected father and an affected mother, that 50% of their children will inherit the allele, just following the assortment and Hardy-Weinberg equilibrium. So 50% of children will be affected with one allele, and then 50% of children will get the healthy allele from the mother, and then will be unaffected. So this is classic dominant inheritance. Briefly, I'd like to mention another form of genetic variation, DNA copy number variation. And I explain copy number variation to my medical students as holes in your genes. These are big changes where, in fact, big pieces of the gene have gone missing, like holes in the genes. It could also be duplications. Big pieces are duplicated, but most often in the LDL receptor, these are deletions of the genes. These are usually would be missed if you don't think about it. This just shows a paper that we had from 380 patients with FH in my clinic, 388 patients. And it turns out that this method to detect the holes in the genes, the copy number variation, there were 38 patients. So 10%, 38 out of 388 have this form of variation. So you need to have special bioinformatic processing of the sequencing results to find this type of variation. And this slide shows the map of all the DNA variants in the patients that I am taking care of from my clinic in Ontario, Canada. So here, this is the map of the LDL receptor gene. Above the line are all of these small variants, this sort of single nucleotide changes, and then below the line are these holes in the genes, the big deletions. And you need, we've designed our sequencing panel that just with one method we can detect all of these possible variants. So this is the thing with FH, is that everybody, especially in a cosmopolitan center, everybody has their own rare variant. You cannot just do it with a single assay, looking for one single variant. You have to look for all possible variants, all 3,000 or more variants. So this is accomplished with next generation sequencing. And this slide shows that now we know that this is the genetic heterogeneity of FH. I mentioned the main gene is the LDL receptor gene, which explains about 85% of patients. ApoB I mentioned, about 5 to 10% of patients. PCSK9 about 1%. And then for the homozygous FH, autosomal recessive hypercholesterolemia, there's a fourth gene, the LDL receptor adapter protein or LDL receptor associated protein. These are very, very rare patients, and they present with a homozygous FH phenotype. There's also some examples of where ApoE and lysosomal acid lipase, and then the genes that underlie cytosterolemia can produce a phenotype that resembles familial hypercholesterolemia, so we have to account for those, but those are very, very rare. Now I will switch gears and talk about polygenic effects with common variants. So here is, on the left-hand side, is the same picture I showed you before of a DNA variant, except this, and it looks the same on sequencing. It's the sequencing gel, but this is different. This particular variant is common in the population. It's not 1 in 300 or 1 in 1,000. It's almost 50-50. 50% of people, or 50% of alleles are one type and 50% of alleles are another type. So as a result, when we then screen the population, there are a lot of people who have 2 copies of A, one from each parent, or homozygotes for C, or heterozygotes. And these are very common. I mean, if we're just sitting in a group of people, many people will have one genotype, many people will have another. And the thing with this type of common variation is most of the time it has no effect on the trait that we're interested in, but sometimes if it's in a critical gene, this can actually have a slight effect on the trait we are interested in. These you may have heard about it, SNPs, single nucleotide polymorphisms, different from a rare pathogenic mutation that I showed you before. So this is how SNPs would have their effect in the population. So here we have say LDL cholesterol, and it has a distribution in the population. And then we have a bunch of people, everybody has LDL cholesterol, and we measure their levels. And then we check to see, after we genotype them, what is the relationship between the genotype and the phenotype of LDL cholesterol. So here we use a gene chip, microarray, and we start, and with the microarray we can do the whole genome, 6 million, or we can impute up to 20 or 22 million positions, and so it's not just like one SNP at a time, it's like the whole genome. But we start, okay, let's start on the top of chromosome 1, and we look, and remember I told you there are 3 kinds of people for a biallelic polymorphism: homozygotes for A, homozygotes for C, or heterozygotes. So here's an example where in fact there is no difference in LDL cholesterol. All 3 kinds of people have the same LDL cholesterol level. So we say, okay, we don't care about that. That's okay. Let's move to the next one, the next on chromosome 1, and we just go down the list and we'll see. Maybe they have a difference in LDL cholesterol. So we go down, polymorphism. Eventually we see something like this. We see here is a polymorphism. The 3 kinds of people are actually different for LDL. So maybe this gene is important for LDL. Now it's not FH. It's not like, a difference of, 8, LDL of 8. This is like, 3.1 versus 3.3. You can find it in the population. It's a very small effect, but it's statistically significant and it's robust. And sometimes we don't even know what the gene is doing. This is the way new genes are being discovered for traits. So using down here this so-called Manhattan plot, we can then do 6 million or a large number of statistical tests, and we show the p-value on the y-axis. So down along the x-axis, this is the genome with all the chromosomes laid end to end, to create a linear map of the genome. And then every one of these dots is a p-value, and that for a position on, say, chromosome 6, you can see here on chromosome 6 or here on chromosome 19. So what this shows is that when all of the statistics are completed, then there is something going on chromosome 19 where there are many SNPs consecutively, or many positions that are giving a highly statistically significant association with LDL. So it makes you think, interesting. Could this be a gene related to FA or to LDL metabolism? So it turns out, yeah, that in this case, yes, it is. It's the LDL receptor itself. But this is not FH. This is just like the difference of LDL of like 3.1 versus 3.3. Okay, this is different from the other kind of variation that I showed you, the rare variant that is like fully explaining FH. This is one just a little bit raising LDL. So we go through, we do this kind of experiment, we find all these common variants, and we can make a list of the ones, say, that have the biggest effect. So, and this is the so-called, if you want, the Mendelian randomization, or this is how we build polygenic scores. It's both shown on this figure. So we have the moment of meiosis, and then these LDL raising alleles are then randomly distributed, depending on what the individual has inherited from their father or mother. But we know that, for example, these are among the top 10 loci. Kind of interesting. It's LDL receptor itself, not FH, right? Not FH, just little effect. Common variant that little bit raises LDL. ApoB is here. That's kind of good. Out of like 30,000 genes, this method found that common polymorphisms in ApoB raise LDL. And here's other ones that we know, PCSK9, that's kind of a good one. So it's interesting, the 3 main FH genes of rare effects also have common polymorphisms that slightly raise LDL. Anyway, we can then take all of these and put them together and create a score. And so if a person is really, really unlucky, they're always inheriting alleles that will raise the LDL cholesterol almost to the same level as if they had a single big mutation that fully explained, just like the single pathogenic mutation. So this is how polygenic risk works. And here is some data from my lab that's showing that, for instance, in patients with normal lipids, so that's this 1 kg, these are normal lipidemic people. There are no mutation. There are no people that are FH mutation positive, okay, that have normal lipids, and the one but then when we look at the ones that are mutation negative, so there's 1,000 of them, and we take, say, we choose our high polygenic score. We create a polygenic score like I showed you, and we say 10%, like the 10th percentile is a high score. So here, 11%. So 11% of normal people, so it works out almost perfectly. We create our score should be 10%, 11%. Okay, well, it's close enough, all right? 11% have a high polygenic score in the general population. Now, if we look over here on the right side, these are patients referred to my clinic with FH. The doctor thinks this could be an FH patient. So here, when there's an FH mutation present in the mutation positive patients, it's the same thing as the general population. The distribution of the polygenic score is the same. It's like 11% of people have a high polygenic score. But if we look at patients referred and the doctor thinks they have FH, but they have no big mutation, they don't have the FH mutation, many more have a high polygenic score. Now, it's not 100%. People think, oh, it should be 100%. If you don't have a mutation, must be polygenic. Well, not really. Depends how you define polygenic. If you are very liberal with your definition of polygenic, then yeah, you can get a very high percentage. Here we're quite strict. The high polygenic score is the top 10th percentile, so we see 30%. We would expect 10% if there's no association. Here we see almost 30%, odds ratio of 3. If we were, more liberal with the polygenic score, say 50th percentile, we could get it up to 80%, and we say, see, look, most people have a high polygenic score, but then 50% of normal people would have a high polygenic score as well. So, like, what is the use of that? So it's better to be stringent with setting the level of the polygenic score. And now, in my clinic, then we show here are then patients referred to my clinic. The doctor thinks they have FH. About half of them have the single gene variant, the single gene mutation. About a third of them, that one that I just showed you, has a high polygenic score. And then the rest have got something else, very high Lp(a), or, we don't know what they have, but it's neither of the above. So there's obviously things we still need to learn through research. Now, if we are more stringent with the phenotype, if we are looking at LDL above 8, very high LDL, look, almost 100% have a single gene mutation, okay? What we think of as, classic, FH, LDL receptor, single gene. Yeah, but I mean, these people are a smaller proportion. So yeah, the stricter you make the phenotype, the more likely it is to be monogenic. But now many societies are saying, at LDL above 5, you should think about FH. But then when you do that, still the majority are monogenic, but then a high percentage are polygenic as well. And so here is our suggested genetic evaluation when a patient is referred for FH. Targeted sequencing for the major genes, include the minor genes, check for those copy number variants, remember holes in your genes, and then also simultaneously do a polygenic score. You can measure Lp(a), sometimes a high Lp(a), very high, it will artifactually appear as FH. And then maybe things like, plant sterols, cytosterolemia. But this would be then to do comprehensively assess. Now, what about genetically high triglycerides? So the last few slides we'll talk about triglycerides. So these are some of the clinical manifestations. Again, we wrote this for Canadian doctors to make them more aware of the problem of severe hypertriglyceridemia. So triglycerides this high, with chylomicrons, usually triglycerides above 10 millimoles, and so a small proportion are genetic. Most of them are polygenic. So briefly, another case of mine, a patient. She was a 26-year-old university student. We also had diabetes. She was not complying with her insulin. She was admitted with acute pancreatitis, diabetic ketoacidosis, adult respiratory distress syndrome, admitted to the intensive care unit. Her cholesterol was 41.7. Her triglycerides were 110. You can see her diabetes was poorly controlled. So she was started, and the DNA analysis subsequently showed that she had polygenic hypercholesterolemia. You would look at this and you would say, oh, that must be familial chylomicronemia syndrome, LPL deficiency. Not really. Triglycerides have much different genetics than cholesterol. You cannot try to make it fit your idea of FH. Heterozygote is medium, and then homozygote is severe. This must be a homozygote, because when she was treated, ventilation, fluids, pressors, insulin, fenofibrate, when she went home, her triglyceride was 1.6 when she was then taking insulin, and so 1.6. So how can you say that's a homozygote for anything? Triglyceride, very, very different. You cannot try to make the triglycerides fit the FH model. This is my main message to you today. Now, there is monogenic chylomicronemia for sure, familial chylomicronemia syndrome, which is more like a pediatric disorder, and there's like an absolute deficiency of lipoprotein lipase or its cofactors. So 80% of those patients have LPL, lipoprotein lipase defects, and then there are 4 other minor genes: GPI, HBP1, ApoA5, ApoC2, LMF1. So these 4 genes together account for about 20% of the susceptibility to severe familial chylomicronemia. And here, this is the same thing, so that in fact, what we are showing here is a polygenic score. I showed you before with the diagrams on the side, but now these are called violin plots, but it's still showing the distribution. So here, for the normal lipidemic population, the reference cohort, 10% has a high polygenic score, like 9.5%. Okay, we have our center for triglycerides. This is not for LDL. This is a similar score for triglyceride. But when we look in patients with triglycerides over 10, it's 34% has a high polygenic score. Another cohort, again, the same thing, and then on average it's around 33. So again, the same thing, but mostly high triglycerides are of this nature. When we look for the single gene changes, and especially 2 copies, very rare in these cohorts, as I will show you. Yeah, so our panel then, we call it Lipid-seq. We've been using it since 2012. We've sequenced over 6,000 patients. So it simultaneously detects monogenic variants on that long list. It then simultaneously detects polygenic variants. So if you go to a private company, they won't do the polygenic scores. And then we're conscious of looking for copy number variations as well. So when a patient comes into my clinic, they are seen. We collect phenotype information, which includes demography, biochemistry, and imaging, and then simultaneously genotype running through the next generation sequencer. We do concurrently monogenic assessment and polygenic assessment. And the thing is, we're very familiar with polygenic assessment, so I don't trust the polygenic assessments necessarily that come from private companies, but I do think I certainly understand the polygenic assessment, and so certainly can trust it. And then we review the results with the patients when they come back, and patients are very interested, like they're all interested in their genetic results when they, when they're referred to clinic. So here's the breakdown for patients in my clinic. So probably around 600 cases referred with hypercholesterolemia. So about half, 50%, have monogenic, have the heterozygous rare variant. Another 13% have polygenic, and then there's about a third where we have not determined the basis of their hyperlipidemia. And then for patients referred for hypertriglyceridemia, it's quite different. So the pure, like what you think of as lipoprotein lipase deficiency, or, so these are all triglycerides over 10. That two alleles, biallelic or homozygous, it's very rare. It's like 1.1%. The heterozygotes are more common, 15%, but remember that like 4% of the general population is heterozygous. So 4% of people with completely normal lipids are also heterozygous. So the heterozygosity is not a guarantee that you are going to get severely high triglycerides. It's an odds ratio. It's like a probabilistic, but it's not deterministic. And then, as I showed you the data about our polygenic risk, so about a third. So here the polygenic risk largely outweighs any large single gene effect. Whereas, for hypercholesterolemia, it was the opposite. Like many more monogenic, and then just a little fewer polygenic. So my final slide for you today, and thank you for your patience and for listening to me. So dyslipidemias, high LDL, high triglyceride. I didn't have a chance to talk about combined hyperlipidemia or depressed HDL, but you can read about this in some of the references I gave you. So for monogenic dyslipidemias, there are 25 genes and 25 disorders. For a severe LDL increase, so for example, clinically thought of as familial hypercholesterolemia, monogenic and polygenic are roughly around the same scale. It's usually more monogenic than polygenic. But for severe hypertriglyceridemia, triglycerides over 10, way more polygenic than monogenic. I mean the pure monogenic. The heterozygotes, we sort of regard them as an honorary form of the polygenic, actually. And then these lipid disturbances that have a genetic basis, so whether it's high LDL or high non-HDL or moderate or high hypertriglyceridemia, Lp(a) I didn't talk very much about today. These all increase ASCVD risk, and the severe hypertriglyceridemia raises the risk of pancreatitis. So again, thank you. It was my honor to speak with you. Thank you for your attention today.
Okay, we are now finished with the presentation by Professor Hegele. I think all of you will agree that has been quite a performance for us, just for us this evening. And now we have time for discussion and questions, remarks. I'll try to answer as much as I could, surely not as efficiently as Professor Hegele will do, but I will do my best. So please feel free to pose a question. You can either use the chat or perhaps you can unmute yourself and talk.
I can read the question from Angelique Linda.
Please do.
How we do not take in account the effect of the microbiome when the genome is the 98% of our organism?
Okay, I think this is a very pertinent question, and microbiota is becoming a hot topic. However, I must say the influence of microbiota on the genetic setting, it's at the best, at least for monogenic disease, is not a major player, although can modulate. And what I can say is there are ongoing studies in relating the microbiota with the phenotype at the level of FH, for instance, where they are studying, but there are no data available for the time being, the impact of different microbiota on the LDL levels or plasma lipid levels in this subject, as well as the relation with the atherosclerosis, because you know the story about TMAO and all these metabolites that become from the microbiota activity in the intestines and in the liver by transformation of tetramethylamine into TMAO. But there are no firm data on how those may be taken in account in a clinical setting directly now. That's as far as I can tell.
We also have a question from Anne Mertens. Do patients with LMNA, PPAR gamma mutations and severe hyper-TG have the same type of lipoparticles as the patients with LPL mutations, FCH?
Well, not really. I mean, they do have some disturbances of trizo, but not as severe as far as I recall as that with lipoprotein lipase deficiency. Lipoprotein lipase deficiency is very, very, very severe as compared to that. That's my recall of the problem.
Angelique Linda has another question. Why do we not take in consideration the increased amount of toxins and EMFs, which definitely affect our DNA?
There is no doubt, but that's a different story. I mean, when you talk about genetically determined, it means polymorphism/mutations. Essentially, we look for a rare mutation for when you have a sort of monogenic disease. Then the toxics and other things may modulate the expression of some genes, or even perhaps induce new mutations. But those are very sporadic mutations. Essentially, these are two different fields. You can look into epigenetics, you can look into different activities that have to do with the expression of the gene, not with the gene itself in this capability to be expressed or not, or be defective or not. Many substances and pollutants and drugs and other things act through also epigenetic mechanisms. Those are poorly understood today. To date, methylation is being studied. The patterns of methylation will be available in short from the whole genome. However, this is very variable and plastic, if I may, structure. So you may not expect something that will be stable over generations, although some epigenetic traits have been documented to be transferred from mother to child.
Okay. Matteo Pero asks, don't you believe that ASCVD risk is present also for patients with severe HTG?
Severe?
Severe HTG.
G with a G, right?
Yes.
Okay, so what was the question? Sorry, Peter, I didn't quite grasp.
Don't you believe the ASCVD risk is present also for patients with severe HTG?
Oh, yeah, certainly I do. I mean, I don't think that there is nothing that can go against what Professor Piro said.
Kjetil Rettersdal asks, you explained that severe hyper-TG caused by polygenic risk might be effectively hypercholesterolemia treated, as shown in your 26-year student. Is it the same with polygenic?
Not necessarily. Polygenic is a number of polymorphisms that are put into the score, and these scores are made up with, if I understood the question correctly, is coming from the putting together the number of alleles. So if you follow, let's say 20 genes, 25 genes, for instance, as has been suggested by Rob, you will have a score of 50 maximum and the minimum of 0. And then you go to that. And that's the way people do those.
We have a question here. What do you think about the role of STAP1 in lipid genetic disorders?
I don't think there is anything proven to date to be important for genetic monogenic disease.
And what do you think about the role of TG-rich lipoproteins on residual risk in statin-treated patients?
Okay, that's a little to do with the genetics, if I may, but however, we can elaborate that. Certainly, there is a role for TG-rich lipoprotein. I don't like the word residual risk. I like better additional risk. Because residual risk means
Robert Hegele
something.
from
means something that Rob wanted to say something probably. What I'm trying to say is, yes, there is a role that's mostly linked to the ApoB, that is the number of particles there and the cholesterol content of TG-rich lipoproteins. So triglycerides are an hallmark of the ApoB containing lipoproteins. So the non-HDL contribution of VLDL to that parameter. And there are plenty of metabolic and genetic and randomization studies showing ApoB is the best performer under those circumstances for predicting risk. So the residual risk, as you name it, is probably related to the amount of VLDL and the cholesterol that is carried by VLDL, and probably the number of VLDL. Which specific particle within the VLDL is atherogenic, it's more difficult to define. Definitely the ones that do not cross the endothelium, so those are chylomicrons, and the chylomicron remnants larger than 700, 800 angstrom are unlikely to be pro-atherogenic, but their content of ApoB as compared to triglyceride is quite low. As VLDL becomes smaller and sort of remnants, if you wish, then the percent content of ApoB and the actual contribution of ApoB and cholesterol becomes larger, and those are most likely to be the atherogenic ones.
Gustav Lepkowski asks, which database do you recommend to use to evaluate pathogenicity of the genetic variations? Only ClinVar or others as well?
There are several, and I may ask my co-workers to send you a number of them. As a matter of fact, we use 4. So please send me an email, Gustav, and I will send you the precise programs that we are using. Nevertheless, these programs are just in silico, so you will never be able to say something definitive from that. You can only guess what is more likely to be or less likely to be. Confirmation made by family history, making screening through the family, as if there is a family history, and just passing of the genes over generation, that would be much stronger evidence. Those are the suspects may become responsible for something.
We have a few raised hands, and I have unmuted your camera and microphone. So Viktor Gurevich, if you want to ask a question live, it's okay. During the time that you start your camera, we can take a question from Olivier Duchamp. Would you recommend the use of polygenic score for hypercholesterolemia or hypertriglyceridemia in clinical practice of lipidology?
Yes, Olivia, this is a very nice question. And the problem with polygenic scores is in themselves, as you might have seen from several publications, all of you have seen, they do not add much in a risk evaluation. The added value on the ROC curves on evaluation of risk is poor. However, there is a problem there that is related to how you use those scores. And we are finalized now. You may see, we had a paper, an abstract with Brian Ferencz and American College last year, indicating that there may be ways to make much more profitable the knowledge of those polygenic scores. And there are circumstances under which you can play the classical risk factors and make their contribution very strong, but always in the presence of predisposing factors that are the actual value of LDL cholesterol or blood pressure and so on. So there is a mix between gene and endeavor and the area where you live, your attitude to lifestyle. If you take that in account by very rough evaluation of some of the parameters that are causal, like blood pressure and LDL cholesterol, then the genetic scores are very, very good discriminators.
We also have a question from Kjetil Rettersdal, who's actually online here.
Yeah, I can see him, half of him.
Yeah.
But
half of him.
I'm not sure if I have the technique right here, but
can you speak up, please, Katie?
Yes.
Okay. Speak up with your voice because I don't hear you much.
Can you hear me?
Yeah, now it's fine.
My question is regarding polygenic hypercholesterolemia versus polygenic hypertriglyceridemia, because the case that Rob showed with this woman that were perfectly well by quite common common treatment made me think, is it the same with those with severe hypercholesterolemia, which is caused by many different genes? Can they be treated effectively by diet, by physical activity, just like the hypertriglyceridemia?
Yeah, that's what I was trying to say, Kejil. The point is, when you have a polygenic score, the contribution to LDL cholesterol, that polygenic score per se, as an average, is not that high. The actual value is a matter of 15 milligrams per deciliter. So that's not something that, so if you treat them with diet and so on, they will respond well because there's nothing with genetics that it will hamper the effect. But as I said, this polygenic predisposition taken to the patients who are more sensitive to environment, to diet, things like blood pressure and so on, will go very high. So that will help you to identify those subjects that have to be taken in account early, because they will be likely the ones that will develop earlier the disease. Not for everybody, but for a selected population will work much better. And this is the future. It's not something you can apply now, but wait a few years and you will get this kind of approach.
Thank you. I hope I
No, invece è bella, sai perché? Non solo è allegra, ma poi ci sta molto bene con Ciao Darwin, con la serata Darwin, perché parla di...
Okay. Yeah, there was someone on the beach.
Roberto Hegele says hello from the beach.
Yeah. Close his camera, please.
Yes. Victor Gurevich has a question.
Hi, Victor.
Hi. First of all, I'd like to express my admiration. It's a very interesting and good structured lecture. And your answers also. You partly already answered it on my personal question, but I'd like to ask again. In clinical practice, we have a little bit gap between our genetic knowledge and our opportunities with regard to pharmaceuticals. And sometimes, and very often, our doctors in my clinic indicate full genetic investigation to our patients, especially young doctors. And when they obtain the results,
I don't know what to do.
They look at it as a known goal, but can't advise our patients anything additional. And I think, and so on. Yeah, well, that's my question.
I got your point, Victor, and I think you are completely right. I mean, to date, putting this information together is just an exercise that has to do with research, not with clinical practice for the polygenic scores, at least. Obviously, monogenic is a different story because monogenic is easier to understand. The polygenic, we will need more time, but I'm pretty much confident that they will find their way and their place together with other evaluations in order to spot the people who will be likely to be targeted, to be seen and followed intensively at early ages in order to see whether they are keen to develop disease, because those are the ones who will develop the disease further. But that needs to be put into an approach that is beyond our minds, has to go with artificial intelligence. So when we have everything ready, then we'll be up in a condition to use the polygenic scores. To date, That's my personal feeling, though. Polygenic score are more for research, not for immediate clinical applications.
Yeah, I agree with you here. Yeah, but we are waiting for it. That's sure. Thank you very much indeed. Yes, again. Thank you.
So we have a question from Olena Michenko. What's your opinion on the assessment of the polygenic risk score for cardiovascular risk prediction as presented in an open lecture during the Congress by Antwi Hansen?
I already answered that.
Okay.
And to the others, so I think that's more or less what I said.
Okay. We have a question from Antonina Diamanco. What do you think about the response to therapy in subjects with high polygenic risk score, both hypercholesteremia or HTG?
There are only a few data. One data. We need someone to close their mics. Okay. There is only one paper I do remember on that area, and actually there is not much of a difference in there, but that makes sense because they are not so extreme to abolish the metabolic responses to a drug that we are currently using, like statins or ezetimibe or PCSK9. So there is no reason to believe there will be a difference. What you can see, there are some studies where they had analyzed post-hoc the role of polygenic scores and to see the response to therapy. And the people started with a higher risk for events, but because also they started with a higher LDL, by the way, and they got a larger response because it was proportional to the degree of response. So nothing serious, but in terms of reduction, of LDL, you don't expect much more.
So I think we covered all the questions in the chat. So that if
we are
no
on time?
one has, yes, more or less, 2 minutes past.
Okay, that's fine. 2 minutes we can accommodate. Okay, if there are no other questions, let me thank all of you for participating. This has been the first attempt. So I would be more than happy if you can send your comments to the office. If you have anything that you feel like should be improved or made it easier to use, please let us know, because next time we can take adjustments. Again, thank you very much to everybody for participating. Thank you very much to the office, Peter, for organizing all the system. Thank you again, and bye, and see you by the end of the month. Bye now.